hard. But the first metric we struggled to meet was actually improving symptom burden. And so the nursing staff were very used to screening symptoms, but not necessarily how to treat symptoms. And that required quite a lot of in-servicing. So they were taught to have conversations, to understand the expectations of patients and about what the non-pharmacologic interventions were. We developed the one-pager that they could give to the patients and talk through those non-pharmacologic. But then when it came to instituting medications, if that was required, that's often beyond their scope of practice. And so then it was working with the nephrologist to say, okay, look, we need to now start some medications or potentially consider medications. Here's our algorithm. What do you suggest? And it took longer then for the nephrologist to come in, and there was a lag there because not every nephrologist, while they may have accepted conservative kidney management, felt that they wanted to be treating all the symptoms. And so it was understanding and accepting that that was a core responsibility and that we as a program were going to take that on. And eventually it happened, but I have to be honest, it was 12 months before we actually saw a true shift in improvement in symptom burden.
How has your thinking about treatment of pain in patients with kidney disease changed over time?
I'm not sure it's changed tremendously, but I think as we age, but as we become more experienced just as clinicians, I think we do become increasingly sensitive to the very fragile balance between risks and benefits of everything we do in medicine. And the use of opioids is a really good example of that. And I think most things used in excess are rarely good. And just like opioids, escalating doses cause escalating harms. So I think there's an increasingly cautious approach, but it doesn't change my overall philosophy that many patients are going to require pharmacologic intervention, but it has to be done extremely mindfully, really understanding that balance of risks and benefits.
Okay, and so in your article from last June, you talked about non-pharmacologic therapies, and you talked about all sorts of wonderful things that it is very difficult for us to get for our patients in this country: acupuncture, massage therapy, cognitive behavioral therapy, mindfulness type treatments. Are those available in Canada?
I'd love to say yes, but I would be lying. I think it's not that they're not available. We have wonderful chronic pain clinics, but they're not necessarily easily accessible, especially for patients that become more frail, more vulnerable, and the wait lists are long. So I think many of those things are difficult to access, but there's many other things that can be done. So when I think of a non-pharmacologic approach, we often underestimate the power of the therapeutic relationship we can establish with patients. And what is really critical is, first of all, acknowledging the patient's pain and acknowledging their suffering with it. We need to understand the impact that the pain is having in the patient's life, their ability to function, other symptoms, ability to sleep, their overall quality of life, because without that, we can't acknowledge their suffering and we can't actually really truly develop effective strategies. So just having that conversation with the patient can really be quite therapeutic. Then the second level in that non-pharmacologic approach is actually having the patient understand the nature of chronic pain. When they understand the nature and they understand that it's not always possible or even necessarily needed to completely control pain, their focus can shift a little bit and it changes their expectations. And I think that is also really important. And then we start having a very different conversation. what is it that you need from a pain management strategy for you to be able to live well? What's most important? Do we need to help you ambulate better? Do we need to help you sleep better? And we can focus it, and then all of a sudden it becomes a little bit more manageable. I think the next step is then looking at other symptoms. These patients don't just experience pain, they have all these other complex system clusters. And when the burden of their other symptoms gets so high, insomnia, sleep, anxiety, restless legs, whatever it is, their ability to cope with their pain is that much less, and it becomes the chicken or the egg. And also, are they dealing with end-of-life care issues or psychosocial issues that are also causing them distress? If they're having to deal with all of that, even a little bit of pain can become unmanageable because it's the straw that breaks the camel's back. So I really look at dealing with pain in a very holistic manner. I look at some of the other things that I can potentially treat that will actually increase their capacity to deal with chronic pain. Then it's a matter of maybe treating them those other strategies. And it might just be relaxation techniques. What do they love to do? Is it music? Is it visualization? Gentle exercise, keeping them active, can be critical. And even those patients that are quite frail, have multiple comorbidities, they still benefit from daily physical activity. So we really encourage that. So all of that can be done before we even go to all those other things that you mentioned.
So who does that? You talked about listening and how listening can be therapeutic and acknowledging their suffering, and then even looking at all these modalities. Who actually does that? Is it the nephrologist? Is it the nurse?
We all need to take responsibility. I think if we get into this role, it's your job. No, it's my job. It is all of our jobs. And I think each of us have a strength. I certainly view this as my responsibility to acknowledge this and deal with this. But I also review it as my nurse's responsibility to screen, to let me know if I'm missing something, to encourage the patient to talk about the impact. I want to work together with it. It's the pharmacist's responsibility in terms of adverse effects of the medications. Is it doing what it needs to do? The social worker can have a tremendous role in determining psychosocial impacts and other strategies. We all have to share in the responsibility.
Oh, that's great. I mean, it's really a team effort. It's a multi or interdisciplinary team effort. So this has been great, but I'm wanting to be mindful of your time. So I'm wanting to ask you one more question, and then if there's something that I haven't addressed that you thought was important to address, please feel free to do that. Of all the different symptoms, which one do you find the most challenging to treat?
Fatigue. Definitely fatigue.
Okay, yeah, it's we don't have an answer for that yet, do we?
We don't have a great answer. I think there are many things that we can do, but it is the most common and most distressing for patients, and it's the symptom that we've seen the least amount of work focused on, and we really don't have a clear consensus on effective strategies. So again, it's really trying to understand root causes, looking at other symptoms that can be contributing to fatigue, dealing with those that you can, having the patient go through energy conservation strategies, having them focus on things that are most important to them. Again, the gentle exercise. But honestly, if there were one symptom I would love to see increased research and work on, it would be fatigue.
Yeah, my experience is, because I ask every one of my patients who gets a successful kidney transplant, what's the biggest difference? And every time I have not coached them, I have my old energy back again. Is that your experience too? Absolutely.
They will say it's the energy. I hadn't realized how tired I was. Yeah.
Yeah, and in fact, some of our older patients who make the decision to stop dialysis, it's because they are frankly exhausted. They're so tired, they just can't keep going. You know,
Yes.
they may have been on dialysis 10 or 15 years, but they are done. It's very interesting.